Hi guys, we are going to go over postpartum assessment so that you guys know how to do this when you go into clinical. And some of you are going very early like we've already talked about, so it's important that you know how to do a postpartum assessment today. So I am videotaping this so I don't have to repeat it so many times, and I will make it available to you guys so you have it as a resource. Excuse me not having on a lab coat, but here's the gist of a postpartum assessment. The postpartum assessment is a very focused assessment. It covers an acronym, BUBBLE, B-U-B-B-L-E, and I'll add a couple of more letters in a little bit. So sometimes you have a bubble he or a bubble her, but right now we're just going to go over the bubble and then we'll add the others in a minute. So if we go from a head to toe fashion, which is always a good idea, except for when you're in clinical and 10 other things are going on and you can't do the breasts first. You can't even do the uterus just yet, but you need to get other things done. So, but in the checkoff that you guys are doing for me, you will proceed from head to toe. So the first B in bubble stands for the breast. You need to do a breast assessment. You do look at the breast, whether the mom is breastfeeding and or bottle feeding. It's preferable that you don't do a lot of touching to a breastfeeding mom's breast, because the more we touch, the more we stimulate the breasts, it will encourage milk supply. So I said that exactly opposite. It's best that you don't touch a bottle feeding mom's breasts. With a breastfeeding mom, so it's an asking question, or hopefully to know from her chart or the nurse reported off to you before you ever got there, is your patient breastfeeding or bottle feeding? And if she's breastfeeding, you do look at her nipples, both of them, and check for trauma. So you're looking at the areola and the nipple, and you're assessing to see if breastfeeding has caused trauma to her nipples. So cracking, bleeding, ulcers, anything that looks different than a normal looking areola, intact skin, you're documenting and helping with attachment of the newborn, because attaching a baby to a breast sometimes leads to trauma. And we need to get that fixed sooner rather than later. So asking your lactation consultant to come in and help out with that would be a good idea if you see one of the aforementioned things that we just talked about. You can palpate a breastfeeding mom's breast for engorgement. Engorgement means the milk's coming in. It doesn't usually happen until 2 to 3 days after the placenta has come out. So usually that's not happening until they go home. If she's bottle feeding, you are not touching her breast, you're just looking. And you're looking to see if she has any signs of mastitis, which would be unusual this early. But it's also more about just educating that mom. You look to see if she has a tight-fitting bra on. If she does not, you want to encourage that. A sports bra, a well-fitting bra that holds her breast firm to her chest, because the more that they are free, breast tissue wise, the more milk will come into her breast, and we're trying to prevent engorgement. So if she can wear a tight fitting bra for the next 7 days, 24 hours is preferable. When she gets in the shower, she can rinse off her breast, but it's a good idea not to let the shower water hit her breast, because again, that's stimulation to the breast tissue and will allow milk to come into her breast. So no stimulation, and it's a good idea to say that to her partner as well. So that's breasts. Make sure that there are no signs of trauma, nothing that we need to do to adjust breastfeeding. Ask her how the breastfeeding sessions are going. And if she's a bottle feeding mom, make sure we're not seeing any signs or symptoms of engorgement or infection, and we're educating her about how to take care of her breasts. Ice packs are good for engorged mom's breasts, but we want to prevent that engorgement from happening in the first place. The next acronym letter is U, so bubble, B-U. You're going down to her uterus. You have to assess every postpartum mom's uterus. There's a protocol for assessing it, and it is the same as the vital signs post-surgery. So every 15 minutes for the first hour, every half an hour for the next hour, and hourly for the next 4. And you assess sooner if you need to, and that's nursing decision. What you're assessing that uterus for is to make sure it is firm and not boggy, to make sure that she's not having a tremendous amount of bleeding, to make sure that it's midline in her abdomen, and we'll go over the other thing in just a second. The appropriate way to assess a fundus is to have the non-dominant hand protecting down here at the pubic bone. And what you're protecting is your ability to push her uterus right out of her vagina. So your non-dominant hand is supposed to be above the pubic bone to catch the uterus. Your dominant hand is pressing in with the side of your hand at her umbilicus. Umbilicus is always the landmark that you go for. The uterus will go down in the abdomen about a finger breadth every postpartum day. By day 10, you shouldn't be able to palpate her uterus in her abdomen at all. But while she's in the hospital, it's going to be somewhere U-1, U-2. But you're going in with the side of your hand, not your fingers, because you don't want to damage anything further. And you're starting at the umbilicus with your non-dominant hand protecting, and you're pushing in until you identify the hard, firm uterus, and you're massaging it. You do want to feel it hard and firm. That's good. That means it will not hemorrhage or bleed. If you can't feel it, you keep pressing and massaging until you do feel it firm up, and you don't take your hand away from a uterus that was not firm until it's firm and she's not bleeding. So assessing the location, how far below the umbilicus, and is it midline or is it off to the side? If her uterus is off to the side and you're finding the fundus of the uterus over to the side, that's a sign most likely that her bladder is full of urine and she needs to get up and urinate. Have her go to the bathroom, come back and reassess, make sure that uterus comes back midline. If it's not midline, it increases the chance that she can hemorrhage as well. You're also wanting to check for lochia. Lochia is a word that's specific to postpartum discharge. No other person has lochia except for a postpartum lady. And it comes in 3 phases: lochia rubra, serosa, and alba. You need to know those and remember them and know what each of those stages look like, because it is part of the postpartum assessment. You assess the amount of discharge she has on her pad and document the amount and the stage that it's in. Rubra usually comes first, lasts for a day to 2 days. Serosa is lighter pink, is not quite as much tissue in that, and then she will move to alba. But you usually will not be able to diagnose or use the word alba in the hospital because they don't go through that phase that fast. So we went through B, U, and then we went to L for lochia. So let me go back to the next 2 B's. And the next 2 B's in the acronym BUBBLE stands for bladder and bowel. Those are usually just asking questions. You're asking her, has she emptied her bladder? And if she has, is it a normal emptying? Meaning, you're not holding any urine into your bladder that you're not used to holding. Are you going in a normal rate? Is it a normal amount? And it's not causing you any pain. Bowel is just a nice asking question. Have you been able to have a bowel movement since you've been here? It's not a reason that we keep them or cannot not discharge them. It's a reason that we get them up and get them to the bathroom and do things we can encourage them to go to have a bowel movement for, so that they're comfortable when they get home. So breast, uterus, bowel, bladder, lochia we already talked about, rubra, alba, serosa, except it goes rubra, serosa, alba. And then the E at the end of bubble is for episiotomy. And I hate that we use that word for the acronym, because really we're looking to see if there are any lacerations of the perineum, and you're assessing those for REDA: redness, edema, ecchymosis, drainage, and approximation. Make sure you know those words and that you're assessing lacerations for that. Or if she had a C-section, you're assessing that C-section incision for that same acronym. Lots of women these days are not getting episiotomies. There are some doctors out there still who will cut them all the time, but it is evidence-based practice that it's not good practice to cut episiotomies. So you use that E in the acronym to remind you to check for lacerations. So when I told you before that we go from bubble to bubble he or her, the H stands for Hohenstein, which we are not doing Hohenstein anymore. Hohenstein meant that we're checking your postpartum woman for a blood clot. So the way that you appropriately assess for a blood clot is observation. You look at her lower extremities, you feel for heat, tenderness. You ask her if she's having any pain in her lower extremities, and you can measure circumference if there's an issue where it looks like one leg might be bigger than the other, where she might have a blood clot. But we do not do home ensign anymore, but you do check for blood clots because postpartum women are at risk for clotting. The other, when we go from H for home ensign to E, is emotion. Emotion for us makes sure she's not having any signs or symptoms of postpartum blues or depression. Depression we wouldn't see yet, but postpartum blues can lead to depression. So we're watching out for red flags of that. We know whether she has a history of postpartum depression or depression, which can increase the risk of postpartum depression. The E for emotion also stands for how is she bonding? Is she attaching with that newborn baby? So is she holding the baby? Is she making eye contact with the baby? Is she taking care of the baby? Is she feeding the baby when it needs to be fed? Or any issues that you see. If every time you walk in that room she's on her phone or iPad or watching TV without interacting with the baby, those are red flags, and we do things to intervene in that. If we go from bubble he to bubble her, there's an R at the end. It stands for ROGAM, and we'll talk about that a lot later. Just know that that's what the R stands for. But with this assessment, very focused, breast, uterus, bowel, bladder, lochia, lacerations or episiotomy, home ensign, emotions, is she attaching or bonding with that baby, and is she having any signs or symptoms of postpartum hemorrhage? Obviously there are more things that we might have to assess on postpartum women, but that's the basic that I want you to know today. So when you guys go into clinical in a couple of weeks, you will be able to walk in the room and do those things. So that's it, and thanks.